visual metaphor. It can look very complicated and it can be overwhelming, but I will try and reduce this to a few simple messages. Don't forget that in the middle of all this and under the drapes, there's a patient. And the main message is that this work is done with multidisciplinary collaboration, and these days we cannot touch any patient without a lot of discussion, a lot of thought that goes in the pre-treatment preparation, the treatment itself, and then in the post-operative care that is lifelong. In my opinion, anything that still looks complicated, it can be reduced to simple questions, simple answers, without oversimplifying, but have a rational discussion and come down to basic principles. So about congenital heart disease, I will admit that it is quite complex. As a jobbing clinician, I'm still trying to get my head around it. The anatomy of the heart can be, let's say, destroyed during, embryonic evolution in many different ways. There's a lot of moving parts, and these permutations create different anatomic problems that have a knock-on effect on physiology and the treatment options. So the taxonomy and the mapping of our domain in terms of diagnostic possibilities, in terms of treatment possibilities, can be quite overwhelming. Now, these lesions individually and combined can have varying severity. So having a diagnosis doesn't necessarily mean that you require treatment. It can be mild, moderate, severe, and it's the job of the clinical groups to find out, what treatment and when. On top of that, you have associated risk factors. For example, if you're born premature with low weight, if you have genetic syndromes, these things can pile up and stack up against the patient. I have already emphasized the multidisciplinary clinical work, and in my opinion, this can also be taken to any research endeavor. This work is also time-consuming. Sometimes we work all day to generate a single data point in terms of an operation, or one or two catheter procedures in the cath lab. It can be very costly. It is highly scrutinized in terms of performance and outcome, and sometimes can be emotionally charged, and then there can be some cognitive biases and things like that. So what we do in the UK, people who work in the domain, they have an interest, and in a way they meet with a patient sometimes before birth, and there's people who specialize in antenatal diagnosis, and a lot of the activities delivered in children's hospital. But now, with the success of these treatments, you have a large population of adult congenital heart disease. So, for example, at the Bristol Heart Institute, you have a whole team specializing in this kind of work and working exclusively with adults. In the UK, you have 10 centers doing this kind of work in a hub and spoke model. We look after the southwest of England and South Wales. Within the network, if you like, the tertiary treatment like surgery or transcatheter treatment is done, in our case, in Bristol, but we work very closely with colleagues in Cardiff, Exeter, Plymouth, and many other centers in the area to deliver the care. Another feature is the national audit, which is fairly unique and I would say quite advanced. It started 25 years ago as a procedure-based audit to look at the quality of work and make sure it's adequate. But now it has evolved into some knowledge-generating vehicle. It is very strong in that it is complete, non-voluntary. Everybody, if you touch a patient, you have to put the information in the national audit. It's focused on early survival and complications, but we also have long-term trajectories right now. On the basis of the audit, we've also done risk stratification, and there's adjustment for case mix. And another strength in terms of being able to publish these results is that the results in the UK are overall very, very good, some of the best in the world, and without geographical variation. Having said that, there's still a lot more to be done. What about research in congenital heart disease? If I think about surgical research, I like this quote from The Lancet almost 30 years ago, where the editor described surgical research as a comic opera. I think we have come a long way from that to an extent, and we didn't used to have trials and so on. But even in congenital heart disease, there's been trials. We have in Bristol, there's a BHF chair of congenital heart surgery for Massimo Caputo, who's had some excellent contributions in terms of setting up trials and delivering, translational research and things like that. Still a lot more to be done. I think the world is moving away from surgical trials, and we have some credibility in saying that because, been there, done that. But they're very difficult to, not so much conceptualize, but to fund, to deliver, to pick endpoints that you can get in a reasonable time frame. So in our domain, the knowledge is mostly from institutional data, large hospitals, national registries, and sometimes for arcane conditions or situations, even case reports. So over the years, the complexity and heterogeneity of our patient population has been a weakness for us and an obstacle to doing studies and generating good quality evidence. But if we turn things on their head a little bit, this can be a strength if you have complex multimodal data in an era of advanced data science. Another thing about the audit, it's a busy slide, but NCHDA stands for the National Congenital Heart Disease Audit. And people have thought about linking this to get more, if you like, holistic information about patients' destinies. So you can get survival data from the Office of National Statistics, you can link to intensive care registries, hospital episode statistics. All of this has been done, but it wasn't easy, and this is best described by Christina Padgel. I like the title of her paper, The Road to Hell is Paved with Good Intentions. So the regulatory element of all this has been very hard to do, but it has been done, and we've had, we've outlined some trajectories for specific conditions or operations. I think a game changer was a few years ago when the BHF set up the Data Sciences Center. So this is led by Kathy Sudlow, clinician scientist from Edinburgh, who's also published a Sudlow report recently. You may be aware of this. And it's a very collaborative environment with open source coding, and you don't have to reinvent the wheel. But the main thing is that with COVID, they received the exemption for linkage, and this is still maintained. So you don't have to go through all the regulatory hoops to link data. You can link up with the BHF Data Sciences Center and do the work in one of their trusted research environment. I can draw a parallel with, say, I was interested in a recent talk I couldn't attend, a few weeks back, when people have used the UK Biobank, researchers from Germany, to look at cancer trajectories with advanced survival modeling, and in fact, even new methods. I can see some parallels between cancer and data-rich environments to, what we are trying to do. So, where do we stand with AI and congenital heart disease? We're really in the foothills, and all of this are embryonic ideas. So you can jump like on this bandwagon and say, we're interested, and we are, or have skepticism and say that this will never go anywhere. I still think that the Bristol ecosystem is really very rich and very favorable in terms of not only having some clinicians who are interested, but you have computer scientists, specialists in methodology, regulatory ethical issues, and also there's patient in the loop designs that we're keen on. So the premise for any work is that it has to be collaborative, innovative, and funded. And we want to move from concepts to practical problems. And in fact, in the workshop today, we're illustrating with a few problems that are ready for specialist input. Now, some of our biggest hurdles are in decision making. This is a busy slide, but I want to just make the point that we struggle sometimes with decisions, because as a group, when say a cardiologist brings a patient to our MDT, we have to decide, do we need more tests, or can we make a decision about treatment? When should we do the treatment? What is the treatment, transcatheter surgery? What is the follow-up? What are the costs of these decisions in terms of quantity, quality of life, survival, early chances, and don't even mention cost. So there's a lot of moving parts. And I want to just highlight that people have started to use ChatGPT to inform decision making. And the conclusion in this paper that is appearing or has just appeared in one of the main journals is that the public will soon use this tool. But guess what? I think they are already using it. I was in a launch event in London a couple of months ago, and I was sat next to a young adult who had very complex congenital heart disease, treated in infancy with a big operation. She was heading for more complex surgery. And she did admit candidly that she was going to use ChatGPT to put her information through that and challenge the clinical group about, what they're going to do and how they're doing it. Also, I think the output of these off-the-shelf large language models also depends on the quality of the prompt. As a jobbing clinician, I had this notion that AI is really like a black box magic with hallucinations and stuff like that. But one of my friends said, why don't you try this prompt and put it in ChatGPT and get it to simulate an MDT and a high-level discussion between surgeon, cardiologist, and an imagist. And also ask the GPT. I started to argue with it about what to do next, and then it was answering back based on the granular clinical information that we gave it. It was really very scary in a way, and I think that this technology is here, but do we use it off the shelf, or can we shape this agenda? So this is my last slide, and maybe some food for thought. So I think I'm personally not comfortable to using something that is off the shelf and doesn't really have more understanding around it, and also some regulatory environment, because our names are still on the end of the patient's bed. But I want to think about this as a three-pronged approach. So I think we're in a situation where there's almost too much information, certainly in our field or for our brains, to be computed by the human brain without some computer assistance, not to make the decision in your place, but to inform the discussion, to assist with decision. So there is, first of all, the knowledge domain, where there's a lot of information, and these conditions can be very diverse, by the way. If you are an expert in one condition, doesn't mean you know anything about like the next thing along in our small, like niche specialty. Then you have the richness of UK linked data, which is accessible. And then also you have the patient level data with a lot of useful text, as I have seen personally, but also, let's say, in a not so distant future, you can even put in laboratory data or multimodal, imaging and selected things. So I think this is ripe for proper research design and implementation with, patient, clinician, and researcher in the loop. There can be many challenges. The concept is perhaps simple, how you can augment, the off-the-shelf ChatGPT. But I think we should at least think about these things. And I'll stop here, and I think we can move to other talks.